here now to expand on a handful of ovarian cancer abstracts here at the 2019 ASCO annual meeting is Dr. Bradley Monk, who is the professor and director of the Division of Gynecologic Oncology at Creighton University School of Medicine at St. Joseph's Hospital and Medical Center, Arizona Oncology. Hi, Dr. Monk. We're so happy to have you here today.
Gina, thank you. It's great to be with you again, and I'm so excited about what we're doing in gynecologic cancer, most importantly with targeted therapies.
So let's talk a little bit about that. So we're here at ASCO. What are you most excited about of the intriguing data that's coming out of this year's meeting?
So most importantly, we have the study SOLO 3. So of course we had SOLO 2, which was platinum sensitive maintenance olaparib, and then SOLO 1, which just came out in the New England Journal in December, FDA approved December 19th, maintenance frontline in BRCA mutated patients. But everyone wanted to know, is a PARP inhibitor, olaparib, as good or even better than chemotherapy? So presented at this meeting is SOLO 3. And SOLO 3 is a head-to-head comparison of olaparib versus chemotherapy, and finally we proved the naysayers wrong that olaparib is better than chemotherapy in BRCA mutated patients. So that's really transformational, because the provider had to, do I want to use a PARP inhibitor or chemotherapy? Chemotherapy works well in BRCA mutated patients. Well, now we've proved it. PARP inhibitors, particularly olaparib, is superior to chemotherapy. So I'm very excited about that. I think that's going to lead to another FDA approval. That'll be the 7th FDA approval of a PARP inhibitor in ovarian cancer.
Very cool. So what about some other trials here? So we have niraparib that's being looked at in combination with bevacizumab in recurrent platinum sensitive ovarian cancer. So what's the significance of this study? What do we expect to see maybe?
So as we get more savvy with targeted therapies, we want to add them together. And as we add targeted therapies together, we want them to be instead of chemotherapy. And I already told you, olaparib beat chemotherapy. So how about a chemotherapy-free regimen in platinum-sensitive relapse? So there's a randomized phase 2 of niraparib, PARP inhibitor, versus niraparib and bevacizumab, a humanized monoclonal antibody against vascular endothelial growth factor. And that doublet, niraparib bevacizumab, was amazing. Looked exactly like chemotherapy, what we're accustomed to in platinum-sensitive relapsed ovarian cancer, and certainly beat niraparib alone. And importantly, it was most active in the non-BRCA patients. So I already said if you have a BRCA mutation, a PARP inhibitor is better than chemotherapy. But how do we advance the field in non-BRCA patients? Combinations. And this study, it's a preliminary, it's a randomized phase 2, but it's a proof of concept that combination, in this case niraparib and bevacizumab, really performed at the level that we would expect in the BRCA negative patients of chemotherapy, and certainly was better than a PARP inhibitor alone. BRCA mutated patients, maybe a PARP inhibitor alone is sufficient.
Now, what about also in ovarian cancer? Any other intriguing data that we're seeing in ovarian cancer with PARP inhibitors?
So we're really looking towards ESMO. So at ESMO we have, I think, 3 randomized phase 3 trials moving PARP inhibitors into frontline in an expanded opportunity. So I already told you that SOLO 1 is fantastic, hazard ratio of 0.30, 36-month improvement in progression-free survival of frontline, FDA approved December 19th, but only in BRCA patients. So how about all the other patients? So PRIMA is a Tesaro-sponsored trial looking at frontline initially in those with BRCA-like molecular signature, but ultimately in all comers. And then maybe bevacizumab and a PARP inhibitor together, because I already told you we had a proof of principle in platinum-sensitive relapsed. So this trial called PAOLA-1, also probably to be presented at ESMO, takes frontline chemotherapy, bevacizumab maintenance, FDA approved June 13th last year, frontline bevacizumab, and adds olaparib in the maintenance setting to all comers. So again, it's, I think, current standard of care to use PARP maintenance in the BRCA cohort, but we want to expand that either with single agent PARP, PRIMA, or with bevacizumab, olaparib, PAOLA-1. So again, we're trying to expand the opportunity, and really for you guys, to give you guys more opportunities. You already have bev in all comers, olaparib in BRCA mutated patients, but what about BRCA non-mutated patients or the combination of PARP and BEV? So ESMO is going to be fantastic. I hope we can do this again. You have to come to Barcelona, and we'll see you then.
A quick thing too about what about beyond ovarian cancer too? So any other gynecologic malignancies here at ASCO or looking ahead at ESMO?
Thank you. So we have 2 FDA approvals, recent, of targeted therapy, pembrolizumab and PD-L1 positive second-line cervix. And then we also have MSI-high pembrolizumab in recurrent endometrial cancer. And then of course we have bevacizumab in cervical cancer with chemotherapy frontline. So we got bevacizumab, pembrolizumab twice, so both cervix and endometrial cancer have targeted therapies. But I had a trial in progress abstract here, which I'm most excited about, is that despite all of these approvals and indications, we're not curing more patients. And the most common gynecologic cancer around the world is cervical cancer, and despite vaccination and screening. So our vision, my vision, is to add immune therapy to chemotherapy and radiation in those locally advanced cancers and try to find more cures. And so that study is called CALLA, C-A-L-L-A. Takes locally advanced cervical cancer, which the standard treatment is chemotherapy and radiation, and layers on top of that durvalumab, monoclonal antibody against PD-L1. So that's probably, moving forward, will be the ultimate challenge to cure more cervical cancer patients. We'll continue to make incremental benefits, but that's what I'm most excited about, is the opportunity to cure more patients.
Awesome. Well, Dr. Monk, thank you so much for joining us here today. It was wonderful, and maybe I will see you in Barcelona. Who knows?
I will see you in Spain. Thank you.
All right. Thank you.